Hello, my name is Krystina Lewis, and I'm a registered nurse in the Pacemaker and Defibrillator Clinic here at the Heart Institute. I'm also a doctoral candidate at the University of Ottawa in the School of Nursing. It is my pleasure today to give you a presentation on the state of shared decision-making in cardiovascular disease, which was presented at the American Heart Association Scientific Sessions in November 2015. As healthcare providers, we have the opportunity to share decisions with our patients on a daily basis. For any health-related decision, when more than one appropriate option is identified, shared decision-making can and should be launched. Shared decision-making is an interpersonal and interdependent process. It requires the exchange of information between at least one clinician and the patient. As healthcare providers, our responsibility is to share the best evidence about the risks and the benefits of the options of the treatment, and the patient's responsibility is to inform their providers about their context, their goals for their healthcare, their personal preferences and values in association with the options that are presented. Together, we deliberate. We consider the relative pros and cons of the available options in light of the choices that are presented. We consider the feasibility of acting upon the patient's preferred choice. And finally, we reach an agreement on a high-quality treatment decision, one that is informed and based on the patient's preferences and values. This kind of process has been referred to as the pinnacle of patient-centered care. There is a growing number of studies showing that patients want to be more involved in decisions about their health. And from these studies, we know that patients who are involved and engaged have better health outcomes and better health experiences. In 2010, the American College of Cardiology recognized the potential of shared decision-making to increase the value of our healthcare system. They strongly support both the application and research in the arena of shared decision-making. And as a result, we have seen a significant increase in research being done in the fields of shared decision-making for cardiology, with promising results. But shared decision-making, is it happening in practice? A survey of cardiovascular specialist physicians and also nurses were surveyed, 2/3 of which are extremely or very familiar with shared decision-making. And the same number stated that they are using components of shared decision-making in their practice. While more than 80% of the respondents believe that shared decision-making lengthened the patient visit, almost 60% believed that it increased the quality of the discussion that occurs. But interestingly, even though physicians and nurses often report that shared decision-making is important and that they are actively involving patients, current research suggests that at present there is minimal sharing of decisions and consultations. Here I present a systematic review of 33 studies measured the extent to which healthcare providers involve patients in decision-making. There are 3 key behaviors to shared decision-making that was not consistently observed across these studies. These included acknowledging that there is more than one way to deal with the problem, including doing nothing. Secondly, few studies verified patients' preferred approach to receiving information to assist decision-making, and in no study did they observe clinicians verifying a patient's preferred level of involvement in decisions. So this is one study of many that have been done, but for the most part, they all draw similar conclusions. Shared decision-making is not adequately happening in practice. So how do we facilitate it into practice? Well, there are numerous tools and interventions for patients. These include patient decision aids, decision coaching, access to electronic health records, and launching public awareness campaigns so they are aware of their rights as patients in the health consultation. Tools and interventions for healthcare professionals include interprofessional training to enhance skills and knowledge in shared decision-making, and also integrating prompts and reminders in their clinical practice, notwithstanding the integration of principles of shared decision-making in clinical practice guidelines. Ideally, however, any intervention that is implemented to facilitate shared decision-making should target both healthcare professionals and the patients. And as we move forward this mandate of shared decision-making into practice, the lack of incentive for shared decision-making should also be considered a significant barrier. Rather than incentivizing and idolizing an increasing rate of productivity of procedures of surgery, we should also measure, improve, and remunerate the rate and quality of discussions that occur for when patients are making decisions, and making sure that those decisions are informed and reflective of their personal preferences and their values. Shared decision-making has important implications for both patients and healthcare providers. Patients involved in shared decision-making report increased engagement in their care. It facilitates high-quality healthcare decisions, improve health outcomes such as knowledge about their condition and self-control, and they feel greater involvement and overall satisfaction with their care. For healthcare providers, we are then able to deliver high-quality healthcare, improve the provider-patient communication in consultations, and with our buy-in, we are then able to more readily implement decision support tools in practice. Shared decision-making is and will continue to be a crucial part of integrating patient-centered care approaches in practice, and may very well be one of the components needed to optimize the use of our resources in healthcare. In conclusion, healthcare providers can no longer assume what individual patients want and doesn't want to know. We must extend patients the invitation to participate in decisions about their care. Just as we would want to avoid the misdiagnosis of a medical condition, we must also be cautious about the misdiagnosis of patient preferences. Thank you.